Hello everyone, I am Dr. Sendhil Kumar from Gateway Clinics, Coimbatore, India. I am going to talk about laparoscopic totally extraperitoneal hernia surgery. What are the contraindications for TEP repair in inguinal hernia surgery? One is if there are multiple prior lower abdominal operations, previous preperitoneal surgeries like prostatic surgery or previous inguinal hernia surgery done by laparoscopy, large irreducible or obstructed hernias, and of course patients who are not fit for general anesthesia. These patients are not ideal candidates for TEP repair. I use a midline port. A few surgeons use a camera port in the midline and two working ports on either side. Both are acceptable. We always do with camera in the midline and two working ports on either side. That's how we practice our TEP repair. What are the instruments needed? One is a small retractor, you can appreciate. The second one is a bevel tip trocar, that is oblique tip trocar, and 0-degree telescope. This is the area where we use a 0-degree telescope. And this retractor is Devers type retractor. The diameter of the breadth of the retractor is around 1 centimeter. You make an incision in the umbilicus, and this is how you have to expose the umbilicus. You may use a long artery forceps to open the umbilicus, and by using a 15 blade knife, you start your incision from at the depth of the umbilicus and come towards the lower lip of the umbilicus. So the entire incision will be hidden within the umbilicus, and the length will be around 12 millimeter because you are going to use a 10 mm trocar. The length of the incision should be around at least around 12 millimeter, and you have to expose the anterior rectus sheath. Actually, the anterior rectus sheath should be exposed like this. So incise the skin by using artery forceps. You dissect the fat, and with the help of the retractor, you expose the anterior rectus sheath. Which rectus sheath to enter? That is another question. I am a right-handed surgeon, so I expose the right rectus sheath for right inguinal hernia surgery, left rectus sheath for left inguinal hernia surgery, and for bilateral hernia, we go through the right rectus sheath. Both are acceptable. Even you can go through the left rectus sheath, but we prefer to go through the right rectus sheath. The level of exposure of the rectus sheath is very important. The rectus sheath needs to be exposed at the level of umbilicus. You should not pull the retractor down. You should pull the retractor laterally to expose the rectus sheath at the level of the umbilicus, and make a small nick to the anterior rectus sheath by using a 15 blade knife, and put your long artery forceps to enlarge the incision. Then retract the rectus muscle by using this retractor to expose the posterior rectus sheath. If you want to avoid air leak, you can use a saline soaked gauze piece to pack the wound. That also can be done. And the space is created by using either telescopic dissection or by using balloon trocar and balloon dissection. And you can see various balloons which are used for dissection of the preperitoneal space, and we always do with the telescopic dissection. First question is where to go. This is the view what we get immediately after introduction of the 0-degree telescope. So you can appreciate in this image that the arcuate line ends at one level. Beyond that, you can see only the fascia transversalis, and this is the correct plane. That means you should not expose the rectus muscle fibers. Rectus muscle fibers should not be exposed directly. There should be a fascia covering the rectus muscle, that is the fascia transversalis, and after the arcuate line, the thinned out fascia transversalis needs to be breached to go into the preperitoneal plane. So this is the correct plane, which is avascular plane, and you can appreciate only loose areolar tissue. Then you should change your direction. Initially, our dissection with the telescope is towards the midline, towards the pubic symphysis. Then you change your dissection direction towards the lateral border of the rectus. You have to change your telescope horizontally so that you will be reaching the linea semilunaris. at the level of the umbilicus. So you dissect the rectus muscle, you lift the rectus muscle away from the posterior rectus sheath until you reach the linea semilunaris at the level of the umbilicus. Here you can appreciate there is a gap between the inferior epigastric vessel and the linea semilunaris, and that is the gap which we are going to use it to introduce our first working trocar. The first working trocar, when you place it on either side of the camera port, there is a risk of injury to the inferior epigastric artery, and there is always a risk of injury to the peritoneum. So you have to be very careful. And you can appreciate the incision for the first trocar which we have placed already, that is the 5 mm incision, and the first working trocar is entering between the linea semilunaris and the inferior epigastric artery. Above the, it enters above the arcuate line to reach the dissected preperitoneal space. Now we are holding the camera. The surgeon holds the camera with the left hand, the scissor is held with the right hand, and we try to expand the preperitoneal space. We try to go, now the next aim is you have to create a space for insertion of the second working trocar. This is how we cross the midline to go into the opposite side to make a space for the second trocar entry. The second trocar entry is a mirror image, it's like a mirror image of the first trocar. That is, the incision is placed at the level of linea semilunaris, and the trocar enters as laterally as possible, as close to the linea semilunaris as possible into the rectus sheath. This is an important landmark during the dissection of TEP repair, that is called lighthouse sign. You can see the glistening periosteum over the superior pubic ramus. You can appreciate the midline, pubic symphysis and superior pubic ramus on either side. If you want to go to the lateral inguinal space, this fascia transversalis attachment needs to be divided at the level of the linea semilunaris, so that you can see now we are entering into the lateral inguinal space in this image. And after entering into the lateral inguinal space, this is the image what we get. The peritoneum will be seen, and that is the another landmark. If you are able to see the peritoneum, you use that peritoneum and stay close to the peritoneum until you dissect the indirect sac. And as you come close to the deep ring, you will come across the fascia transversalis sling, which also needs to be divided if you want to expose the indirect inguinal hernial sac. And this is how you should do the sac dissection. Pull the sac with the left hand medially, cranially and medially, and try to push all the structures apart from peritoneum. Leave the peritoneum and remove all the other structures. Just by using a scissor, you move away all the other structures. If you do that, the vas deferens and gonadal vessels will move away from the sac. And after encircling the sac at one level, you divide the sac like this, and you make an the endo loop is applied to the proximal divided sac, so that the air will not, carbon dioxide will not enter into the peritoneal cavity. Medially, the extent of dissection is up to the obturator nerve area. You can appreciate the course of the obturator nerve. And another landmark where you can appreciate here in this image, the vas deferens is going down and it is changing its direction towards medially. It is going down like this, and you can also appreciate crossing of the vas deferens and the medial umbilical ligament in this image. So that is another landmark for the extent of the dissection. This is the completed dissection. You can see the triangle of doom, triangle of pain, femoral area, everything is exposed. This is another view. The midline and the entire pubic arch is visualized, and you can appreciate the bladder is nicely dissected down. This is another view of the completed dissection, where there is a bilateral direct hernia and the entire pubic arch is nicely exposed. Sometimes you come across peritoneal injury during TEP dissection, but if there is any peritoneal injury during the lateral part of the dissection, there is no need to be worried. You put an endo loop to the injured peritoneum, and you can increase head down tilt a little bit more. That is enough to complete the dissection. Sometimes in this image you can appreciate that lateral, the second working trocar initially enters into the peritoneal cavity before reaching into the preperitoneal cavity. Here also you can come across a air leak that can be managed by giving more head down tilt. I'm concluding this video now and we'll continue the remaining part in the next video. In this video, I've discussed about laparoscopic TEP repair. I discussed regarding port placement, midline versus bilateral ports, instruments, incision, creating the preperitoneal space, insertion of the first working trocar, crossing the midline, insertion of the second working port, how to dissect the sac, how to ligate the sac, and how to manage pneumoperitoneum in case of peritoneal injury or peritoneal rent, how to manage these problems. All these things I have discussed about in this first part of the TEP video. If you like this video, please subscribe this channel and see you in the next video. Thank you.